told me I had to do this talk. She didn't ask me. She told me that I had to come talk about this. So, and there's been a lot of discussion and controversy about how risky is a risky donor and what is risk, and is it just infectious disease? Is it more than that? So I tried to put together a few slides today to talk about that with some objective facts about instance of positivity of some of these testings and results that we throw around. And so if you, very informal, if you've ever heard me talk before, you can yell, scream, raise your hand, whatever you want, and we'll stop, or we can talk at the end. It doesn't matter. I have no disclosures to my knowledge, and I don't use off-label medications. So by nature of what we do, organ transplantation takes living tissues from one donor and then gives that tissue to another person, another recipient, for a variety of reasons. But that tissue is obviously doesn't, the timing sometimes is very critical, so we don't have time to test for a lot of things. A lot of the testing we do may come back later. So even though we go through a series and a litany of tests which the government supervises us and tells us what to do, there's still not everything may be completely safe. So we have to put you to work today. So as you've heard, the Public Health Service increased risk, the PHSIR, that's what everybody talks about. Now, does that refer to organs that are, quote, less good because there's physiologically something or structurally something wrong with the organ? Is that a true statement or a false statement?
False.
I have to push your button. You're cheating. Uh-oh. Nobody's voting. Okay. Hmm?
And they're voting 39. It's still open.
Everybody voted. Yep. Just hit the next slide. Uh-oh. The polling's closed. Oh, everybody got it right. You guys cheated because of her, yeah. Yeah, it's not because of the structural quality or the physiological integrity. It's about what potential diseases may be transmitted. So that's what PHSIR stands for. So you guys are very bright, huh? So prior to 2005, we didn't have a uniform way of collecting data and reporting on it, and it was kind of from public knowledge, literature reports to the CDC. But the OPTN discussed in 2005 that they formed a policy and established a committee, which is called DTAC for short. So if you're cool and you can throw around, letters, it's DTAC. Otherwise, it's Disease Transmission Advisory Committee, and that's run by UNOS and gives us an update on what's happening as far as disease transmissions from donors. And it's mandated that we report this information to DTAC about everything that's possibly related to the donor. So these new guidelines, which they put in 13, sort of replaces the old guidelines, but specifically it's looking for the incidence of reducing HIV, HPV, and HCV transmission through organ donation. As some people may want to forget in the room, but in 2007, there was a HIV transmission, and even later in 2009, there was an HIV transmission in New York City in a living donor. And it replaced the old 1994 criteria that was established of the, quote, high-risk donor. So the early fallout over the past 10 years has been that some programs won't even touch that organ. So if a label of increased risk has been put on that donor, the program will not even consider using that organ, and that's a tremendous waste. On the other hand, 40% of the programs end up using more than 10% of their organs from this source, so they're kind of capitalizing on that area where nobody is using them. I guess I have to stay in one place for it to work. Huh? So here's your first case. Now this one, you can't get it all right. Okay, so no cheating. All right, so it's a 35-year-old Asian female and an MVA, declared brain dead. Social history is obtained from a friend. The friend said she thinks she has a sister in the Philippines, but couldn't, kind of connect with her. No IV history of drug use, no history of diabetes, hypertension. Did experiment with, quote, recreational drugs. The ER tox screen was positive for cocaine, opiates, and alcohol. And there's the serologies, which you see. The surface antigen is negative. Core antibody is Hep C antibody, is negative. HIV is negative. Hep B core antibody is positive. EBV, CMV is positive. And the NAT testing for B, C, and HIV are all negative. Okay, you got that? All right. So here's your question. You have to vote again, okay? So this donor is Public Health Service increased risk because of a positive tox screen for cocaine. B, because of the nationality and serology, she should be considered PHSIR. Vaccinated therapeutic titer non-liver transplant recipients should receive H-BIG for 6 months post-transplant. So if you give a heart from this donor to someone, they should get H-BIG for 6 months. Or because of those serologies we showed you, that couldn't happen, so it's just a false positive. You may vote now. We've got a few holdouts. All right. There you go. What do you think the real answer is? B is the real answer. Cocaine is really not, it is, but it isn't. Because she didn't use IV. If you used IV drug use, that puts her at Public Health Service high risk. Intranasal cocaine is not putting you at an increased risk category. She's from the Philippines. Hepatitis B is big there. And what you saw was surface antibody and surface antigen, weren't there. We just had the other things. Nationality is important. Serologies are important. And that just means that she doesn't have active infection, but it lives in the liver, obviously. You really don't need to treat any of the thoracic organs if they've been vaccinated and have an acceptable titer of 1 to 10 or greater. And I just made that up because I could come up with another answer. So when you see somebody who's classified as high risk, it's important to know why they're being classified as increased risk. And then you have to take into account who you're giving that organ to. So is it a risk-benefit ratio like many things in life? So if you don't accept that organ, is there another one going to be available tomorrow or next week or the next month, or maybe not? And then maybe the patient's going to have a complication and they're going to die on your waiting list. The amazing thing is that the big uptick in the reports, so now these are donors, okay, that have been identified over the past decade as increased risk. So now over 20% of organ donors are increased risk. So if you turn down every organ because it has this label on it, you're not going to be doing many transplants. So it really behooves us to understand what all these things mean when they talk about NAT testing positive, NAT testing negative, they're in the window, they're not in the window, et cetera, et cetera. But 1 out of 5 donors is now an increased risk donor. And so some studies done over the past few years have looked at the different things that we mandate for NAT testing. NAT testing stands for nucleic acid testing. And it takes that window period from a standard serology of about 3 weeks down to a period of a few days. And each disease that you see there is a little different. The shortest being HIV can be detected in 3 to 5 days, HIV in 5 to 6 days, and the longer window is with hepatitis B. It may take up to 3 weeks for the NAT testing to be positive. But the window is really markedly shortened from that first column there called standard serology, where it would be weeks to months before you'd really have a positive test in somebody who may have been infected. And then they looked at the different kinds of groups of patients that we have. That these are all people who are considered PHSIR. And then per 10,000 donors, if we had 10,000 of those, what is the chance of having positive testing? And as you can see, when you concentrate on the NAT testing for HIV and HCV, the numbers are amazingly small, like 0.1%. So it's going to be a pretty safe test. You know, unless they're in the crack house with the needle in their arm and their commercial sex worker next to them, I think your window's pretty safe. And they got a lot of blood products on the way to the hospital, yeah. So even though everybody's hyped up about all these incidents of HCV and HIV and all these things, it still remains a very safe organ to use for the most part. And then looking at these guidelines between 94 and 13, 94, if you had men who have sex with men, it's 5 years wait. Now they cut it down to 12 months. So there's been some fine tuning, if you will, and some differences in the criteria over the past 20 years. The 2013 guidelines are the most recent, which will fall into the category of the Public Health Service increased risk. And they just go on and on. They cover every possible category there. So is there any question about the PHSIR? I'm sure there is. Here's an interesting slide too. So what they're looking at is days post-exposure again, and everything by 2 weeks is definitely going to be able to be discovered by NAT testing. So that's another objective point to look at. Here's a really good slide that puts everything together. So your chances of dying from a car accident is on the right-hand side, and your chances of getting HCV or HIV from a PHSIR donor is on the left-hand side. So it's a fraction of less than a fraction of 1% versus nearly 1% on the right side. So these are some talking points when you want to sit and talk with a patient of how comfortable you are accepting that organ for them and carrying on with the transplant. All righty. So just to go back to your serology. So what does this state mean? Back to hepatitis B. So that's usually the area of confusion. So surface antigens negative, core antibodies negative, and the surface antibody is positive. So of those four things, what does that signify? Does that signify they have just a chronic infection that they've dealt with? They've had the disease and now have natural immunity. They've been vaccinated, or none of those are possible. You can't whisper out loud to your neighbors. Yeah, you keep it down. Oh, this was quicker, so you guys nailed this one probably, huh? Here you go. It is C, the vaccinated immunity. And you have to look at titers to be very comfortable that it's truly, they have some immunity. Because just because they receive the vaccinations doesn't mean they necessarily have immunity. All right. Little things that can cause a lot of problems. They're not your children, okay? There are other things that cause lots of problems like that. Here's the next case. So a 4-year-old boy from Mississippi had a transient febrile illness in October of 2009. Kind of lived on the farm, natural kind of state. He diagnosed with influenza by a rapid test. He was seen in the ER. A few days later, or 24 hours later, he developed headache and seizures. They did a spinal tap on him, and they said he had pleocytosis of his lymphocytes in his spinal cord fluid. And the MRI showed these enhancing lesions and edema, and they diagnosed him with autoimmune-mediated encephalitis. Okay? He was readmitted a few days later, treated with IVIG because he got worse, he didn't get better. Then a week later after that, he developed hemorrhage, brain hematoma, and he was declared brain dead. They donated his organs. 4 patients, 3 transplant centers. Both kidney recipients developed neurologic symptoms. 1 patient died. The other thoracic organ developed headaches, and 1 patient was completely fine without any symptomatology. Does anybody know the diagnosis yet? You can choose out of one of those 4. One of those 4 is correct. Naegleria fowleri, Strongyloides balamuthia, or influenza A. What did those recipients suffer from? Remember the first slide, little things cause big problems? There's a hint. All right, looks like everybody's voted. The answer is C, Balamuthia mandrilis. That's right. What is that crazy thing? Huh? I never heard of it personally. It's a free-living amoeba. It's found in soil, mostly organically enriched soil, also called cow manure. It was only first isolated in the 80s, has a high fatality rate. It can cause some skin lesions, and there's only been 70 confirmed cases in the United States, and obviously more than that. But here's somebody, a 9-year-old, that was given a diagnosis that everybody believed, but indeed it wasn't that, and can have a big, big consequence from that. So another case of rabies, I don't know if you remember that one. That happened because they figured out this guy who had worked with raccoons in North Carolina, and bada bing, the recipients ended up with rabies, but they didn't get that from the initial social history. So it's very important, especially when somebody dies of encephalitis or things like that, that you have every possible bit of knowledge you can to help you make that decision. So the mosquito-borne illnesses, you get 5 points if you can pronounce the first word. Chikungunya, yes. It's a mosquito, became popular a few years ago. There seemed to be a change in its DNA or RNA structure that made it more of a problem, especially in Puerto Rico and the Caribbean. But this is found all through Africa, etc. Same with our equine encephalitis, St. Louis, Western, etc. The Zika virus, as you know, has become popular here in Florida the past few years. They have some confirmed cases, but nothing that's been transmitted with an organ yet. And dengue and yellow fever, they're all mosquito-borne problems. So other things with liver transplants especially, you can get metabolic diseases that you may not realize, urea cycle disorders. G6PD deficiency, you can ITP, you can even get foodborne allergies, which is an IgA-related phenomena. It tends to be a temporary thing, but it's still a problem that you have to be aware of. And all these things should fall into a high-risk category when you see them. So, how about tumors? Can we transplant tumors? Yes, we can. But there's really no way to get a true number on this, and so you can quote numbers and statistics and things like that because it's impossible to ascertain. There are certain malignancies which, if you know about it ahead of time, obviously you should avoid, and there are some malignancies which they say, okay, like back in the ATC this year, they were talking about isolated renal cell cancers, cutting them out and using that organ for transplant purposes. So anyways, so everybody's on the same terminology. DTC means donor-transmitted cancer, DDC means donor-derived cancer, and then DOC means donor-origin cancer. So that means usually the frequency and the timing of which you see the cancers develop in your recipient. This is a good study from the United Kingdom. We thank Dr. Watson's colleagues for that. They looked over the past several years and come up with 30,000 transplants, almost 15,000 donors. Keep in mind that these were donors that had absolutely no evidence of cancer prior to their donation, but then was found either afterwards or of the recipients was found in them and tracked back to match their the DNA. So there was 18 recipients from 16 donors, so that's an incident rate of 0.06. And so you can see again, these are very, very low numbers, but not zero. The most common disease was renal cell carcinoma that was transplanted. And the only risk factor they found was age over 45. Hello? But these other things approached, but again, it's just, obviously, as we use older donors, the chances of finding an incidental carcinoma, which was unsuspected, is going to be there. It's not going to be zero. So there's another paper in Transplant, as we talked about, that categorizes risk. So if you have a donor and you know they've had a cancer, what is the risk factor? So can we use low-grade central nervous system tumors? Can we use squamous cell carcinomas in transplant using those organs? And the answer is yes. They fall into a category where the risk they estimate is 0.1 to 1%. So again, it's not zero, but it's very small. They have an intermediate risk of known cancers that's been treated on breast, colon, and even renal cells again. But the intermediate risk, most people won't take a 10% chance, and so wouldn't use those organs. And then high-risk group, as you see there. So your last question. Of these malignancies listed there, they all have a high risk of disease transmission except one. Which one of those would be an acceptable organ to use from a recipient who has a known sarcoma, follicular thyroid cancer, melanoma, or choriocarcinoma? You like voting like this? Yeah, it's fun. It's audience participation, huh? All right, see, you're learning. It's B, it's a truth. It's B. It's a true statement. All right, so because of the critical timing of our transplant, hearts have to be in a matter of hours, minutes, lungs are next. You don't have time sometimes to get all this information that we may need, and then we receive it sort of after the operation. But our job as stewards of providing organs and trying to save the lives of our patients is to inform them as much as we can about the facts. And that's what hopefully we've done a little bit today to inform you that we can make this a fairly safe endeavor. And so there are donors, some are more risky than others. I'd be really a problem. I'd be a high-risk donor. But the risk will never be zero. So hopefully we can have some dialogue and questions and talk. And it's too early to have a beer. So, any questions?
Yeah, really.
Yes, Mr.
So-
Jane.
The high risk classification, I had a question. Why don't they just consider them all high risk and do NAT testing? Is it
They're done. LifeLink does NAT testing on everyone.
okay?
They do. They've because we had that discussion a year or two ago when the mandatory PHS stuff came out, and they changed it to just do everything because of they have a high rate of crime in Puerto Rico. I know, and murders and things like that, and so they were pushing. So we just uniformly had that test done on everyone now, and the living donors. Everything I said about these deceased donors applied to the living donors also. That testing is done on everyone. Is that correct? Yeah.
So is it necessary to keep calling them a high risk?
Because the government says we have to, yes. So if they fall into that category, we have to have a consent saying that they accept the high risk. And then we have to do testing post-transplant in a periodic fashion. Otherwise, we go to jail. UNOS jail, yes.
Do you know what the percent of increased risk donors are for our program?
24%.
That we utilize?
Oh, in our program, no. I know for LifeLink, 24% of their donors are increased risk. At our program, I don't know. I haven't looked at that. Actually, that'd be a good thing to look at. How we utilize ours. Do we shy away from them or do we use them? I think speaking from a renal standpoint, I think we've been conservative until more recently. Now, because of the number we're getting, and we've been a bit more liberal, I think. I don't know. But what about the thoracic programs? You accept these organs?
Yeah, we accept the majority of them.
Dr. Hoffman, where's Dr. Hoffman?
Yeah, we do too.
Okay. What else?
Other endemic diseases, I know in West Nile,
Mhm.
showed up, there was a suggestion that donor or transplant centers look at endemic diseases or diseases that are popping up in your neighborhood.
Right.
That kind of puts the monkey on the transplant center's back, and you really have to ask what's endemic anymore because the way we travel and
Well, almost anything's endemic the way, because we can get diseases from Africa, from Europe, et cetera. So I think it centers around the constellation of symptoms that patient died from. And if there's any concern about an encephalitis, that's the most worrisome thing to me, because that first thing I showed on that one side, the Naegleria, that's an amoeba that lives in fresh water. So you have a water skiing, you're out water skiing, having a great time, and you get a bug burst of air, and then you hit your head, but then you got an amoeba up your nose. Huh? No, there's been cases of transmission of that too. Seriously. Yeah. So.
Dr. Bowers, a question like this. So we see patients as a clinician in clinic for the recipient, and that sometimes they have issue of cancer, they have issue of infection, and I have time. I can ask the infectious disease specialist, the oncologist, to get their opinion, the risk for recurrence of that tumor or infection after transplant. When the surgeon get this call at 3 in the morning, they probably have sometimes 15 or 20 minutes to decide if they want that organ or not.
Yes.
Do you have any resources available to you right there to say, well, donor has an issue of lymphoma 5 years ago? There's any place you can just check and see, or experience mainly?
Well, good judgment comes from bad experiences. But the only paper I know that tried to classify it is that one that they put the known cancers in these risk categories. And most of the bad actors are in the high risk category. So, and melanomas, sarcomas, lymphomas within I think they went back to 10 years, but I don't quote me on that one. So.
How about the intermediate donors? The ones nowadays that we have more prevalence of colorectal cancer.
Mm-hmm.
What happens with those donors that they go on resections and there is no need for chemotherapy, if there is a timing for these donors to be out of donations, or can they be?
Except for carcinoma in situ, the rule of thumb has been 5 years.
Okay. Right.
At least that's what I've read anyway. Anybody else have thoughts? No thoughts? You stop thinking. All right. Melissa?
Both at ATC and the pre-sessions that they had and at the Transplant Management Forum, they discussed a recent article, and I don't recall the reference, where they have shown that the kidneys from increased risk donors actually have a statistically higher outcome than at 1 year.
Higher graft
function. And they are kind of attributing that to they didn't see a difference. They didn't see any worse function in thoracic or livers, but they did see a better function, and they were kind of attributing that to the increased risk category being so much in the younger population.
Probably true. And then we've had a huge uptick of the opiate overdoses and things like that, which tend to be younger also, yeah. So they don't have a lot of comorbid illnesses. Anything else? Well, for good behavior, you get off early today. Thank you for your attention. Yeah, you can't steal those little voting things you have to hand in. Huh?